Hi everyone, I hope you're having a great day. Welcome to your online lecture for Pathophysiology 2. In today's lecture we're covering digestive disorders, which will be followed by another lecture on digestive disorders. And you can see that today we're going to be covering disorders of the gastrointestinal tract or the GI tract. And then in your next online lecture we'll look at digestive accessory organs. So those are organs that can become altered in their function for various different reasons, but these organs play a more of an assistive role with digestion rather than coming into direct contact with food. So some of the common clinical manifestations of gastrointestinal disorders, so we're talking about the signs, the symptoms, really the evidence of disease, involve diarrhea is one example, and this is something that everybody knows what this is and everybody has probably experienced it, but it is defined as an increase in the frequency of defecation and or fluid content and an increase in the volume of feces. Really, it can be described as the presence of loose, watery stools. There are three main mechanisms or pathophysiological mechanisms that can actually cause diarrhea. And you can see that it involves osmotic diarrhea, secretory diarrhea, and motility diarrhea. And we'll talk about we'll define them briefly. When it comes to osmotic diarrhea, this is where contents in the intestine that are non-absorbable or end up not being absorbed can have an osmotic effect and attract water and pull water into the lumen of the gastrointestinal tract or into the intestines. And so we can call these substances that are pulling water into the digestive tract osmotically active substances. There is a secretory type of diarrhea. With this type of diarrhea, the epithelial cells ion transport processes are turned into a state of active secretion. There could also be reduced absorption of ions, so you could have impairment of the normal functioning of the electrolyte pump, and this can lead overall to reduced absorption of water. All in all, you end up with more fluid within the intestinal tract. Certain infections, such as cholera and E. coli, can also cause this type of diarrhea. With cholera in particular, this bacteria has a toxin that ends up affecting the normal pumps within enterocytes. And this, of course, would then be an infectious cause of secretory diarrhea. Motility diarrhea occurs when peristalsis, remember that's the forward movement and really propulsion of food throughout our digestive tract, and that's controlled by muscles. So this type of diarrhea occurs when peristalsis is very high. So we can say increased motility, and it can be caused by, for example, this is just one example, if part of the small intestine is removed. This is termed short bowel syndrome. Maybe a good amount of the small intestine has to be removed, and so this really changes absorption, and food moves very quickly through the digestive tract in these individuals. These are really considered to be what's referred to as large volume diarrhea, so excessive amounts of water or secretions or both within the intestinal tract. Small volume diarrhea is usually caused by inflammatory disorders of the colon, so for example Crohn's disease and or ulcerative colitis, and we'll look at these later on today. Now, what effect can diarrhea have? Well, pretty obvious effect in dehydration, of course, as well as electrolyte alterations. And the two most common electrolyte alterations that can be seen are alterations in sodium and potassium, and this would then lead to a reduction in both sodium and potassium within the blood, because remember, emia is referring to the blood and hypo is referring to low amounts. So let's have a look now at what's referred to as malabsorption syndromes, which is defined as the failure of the intestinal mucosa to absorb digested nutrients. And this, if we're not able, even if we're intaking the food, Those that have malabsorption syndromes, it doesn't matter what they're intaking because their body isn't digesting and absorbing those nutrients, so they're not getting the benefit of it. And there are many different causes of this. We're going to focus on 3 in particular, and they are pancreatic exocrine insufficiency, lactase deficiency, and bile salt deficiency. Remember that the pancreas is both an endocrine and an exocrine organ. So the pancreas, with its endocrine function, is going to produce hormones that are involved in, for example, glucose regulation within the body. So that's part of its endocrine function. But its exocrine function involves the production of digestive enzymes that help break down food. And they do this by leaving the pancreas and directly entering the small intestine. So people that have insufficient production, for example, will end up, as we'll see on the next slide, with absorption issues. Lactase deficiency. Lactase, remember, anything that has an ACE at the end as part of its suffix is an enzyme, whereas if it's OSE, O-S-E, it is representing a carbohydrate or a sugar. So lactase then is an enzyme that is designed to break down lactose. And so people with a deficiency in lactase will have problems breaking down lactose. And finally, bile salt deficiency. Remember that the liver is going to produce bile as one of its many wonderful functions, and the bile will then travel to the gallbladder, where it will be stored there until it's needed. And then when it is needed, the gallbladder can contract and push bile directly into, via a common duct actually with the pancreas, or a shared duct, where it will enter into the small intestine to aid in digestion. Now, why is bile released? Well, bile is released when fats are present within the small intestine. And so it helps with the breakdown because fat is more difficult to break down, so bile acts as an emulsifier to assist with breaking it down. Sometimes it's described as having almost a detergent type of effect or an agitation type of effect. So if you think of, let's say you get some oil of some sort onto your shirt and you put your shirt into the washing machine and it comes out with the oil. Sometimes what you have to do is take that shirt to a sink and use soap and really using your hands increase the agitation to that area to try to break up that fat. And so bile assists with that within the body. Now you can see the different color coding here on this slide when we talk about these common causes of malabsorption syndromes, and then you can cross-reference then to this next slide in what is highlighted in the different colors. And so you can see the red box, the green box, and then this part here is actually supposed to be blue, relating to the pancreatic and exocrine insufficiency. So looking on the left here to start, I want you to think back to normal anatomy when we stress the fact that the stomach, although it is involved in mechanical and chemical digestion, really preparing food and then acting as a reservoir for food before it moves into the small intestine, very little absorption occurs. There's only one example listed here that 20% of the total alcohol consumed is absorbed at the level of the stomach. There's certain drugs that are absorbed at the level of the stomach, but very little absorption occurs in this area. And you can see then that the majority of absorption occurs once chyme has moved from the stomach into the duodenum. And this is where we're getting throughout the duodenum, jejunum, and ileum, but primarily you can see it occurring at the level of the duodenum is where absorption occurs. So still more digestion will occur, but absorption will occur through the wall of the small intestine and into our bloodstream and into our lymphatics. So when we talk about malabsorption syndromes then, we're talking about disorders that either directly or indirectly affect absorption at the level of the small intestine. Remember that the colon, where some additional water will be reabsorbed, this is where, so large intestine and on, this is where the feces is getting compacted and prepared for defecation. Now looking at the right, you can see that this image breaks down the different main forms of substances that we consume and digest, so macromolecules, carbohydrates, proteins, and fats, and we can't absorb them in this state. We need to break them down into their smallest components, so the monomer or the building block, in order to actually absorb it and then utilize it within our body. You can see that in these, what are supposed to be blue boxes, it's referring to pancreatic exocrine insufficiency. And so what you can take from this part is that the pancreas is involved in all three. In other words, it's involved in digestion of carbohydrates, proteins, and fats by producing particular enzymes that digest food, allowing us to absorb it. So when there's an issue with the exocrine function of the pancreas, you can clearly see how it can impact much variable digestion and subsequent absorption. And individuals that have pancreatic exocrine insufficiencies will actually need to take pancreatic enzymes in order to, as a supplement, in order to help digest food and help absorb it. Next up, we have lactase deficiency. So again, lactose is a carbohydrate, it's a sugar or a disaccharide. So in the form of lactose, it is a disaccharide, and it breaks down into a monosaccharide, and it's the monosaccharide that we can actually absorb. That's the monomer, that's the building block. You might also recall that within the brush border of our small intestine, we produce enzymes. And the main enzymes that are produced are lactase, maltase, and sucrase, which have the function, as you could expect, by breaking down lactose, maltose, and sucrose into their monosaccharide form, where we can actually absorb it into our blood. And so these enzymes, these brush border enzymes, they are produced by enterocytes. And loss of enterocytes, or viruses that maybe damage temporarily the brush border or damage these enterocytes, then people will experience a temporary lactase deficiency. So sometimes when people are sick with a particular virus that impacts the function of the enterocytes, they can experience lactose intolerance during that period of time. So consuming milk products can be troublesome. This can also be a problem for young children. So for example, those that were born premature may not have enterocytes that produce the appropriate amount of brush border enzymes. And so in these individuals, it can lead to what we have already spoken about, which is called osmotic diarrhea. And finally, in green, we have bile salt deficiency. Remember, this is relating to fats. We spoke about where bile is produced and where it's stored and why it's released, in that it emulsifies the fats to help with digestion. And in addition, pancreatic lipase, which is an enzyme produced by the pancreas that also assists with the digestion of fat, they will work together in order to digest fat and move it into its absorbable form. So somebody that has no gallbladder, maybe they had it removed, or maybe they have gallbladder problems, then malabsorption of fat will occur. And so these individuals can suffer from what's called steatorrhea. And this is pretty easy to identify visually. And this is where their stool is very fatty and white in appearance because they're not absorbing the fat, so it moves through their system and it ends up being a larger component than is normal of their feces. We'll move on now to talking about gastrointestinal bleeding. And when there's a GI tract bleed, it's generally going to be considered as being either an upper or a lower GI bleed. An upper GI bleed in particular will cause hematemesis. And we've talked about this term before, referring to the vomiting up of blood. Not to be confused with hemolysis, which is the coughing up of blood. It's important that if somebody says they bring up blood, is it coming from when they cough, or is it something that they're bringing up from their either esophagus, stomach, or upper part of the small intestine or the duodenum? Now, hematemesis is, as I said, broadly defined as vomiting up of blood, and it can either be this bright red color, or it can have a coffee ground appearance. And if it has a coffee ground appearance, it's because the body has actually digested some of this blood, and it gives it a very different appearance than that fresh red blood. Another term to be aware of is called hematochezia, and this occurs when there's bleeding in the stool, but it's usually a bright red blood. And this is more typical of GI bleeds that occur very fast. So there's very fast bleeding. There's not enough time for the body to digest it. Much it moves through the body and ends up bright red in the stool. And the next term then to speak of is called melena, and melena refers to very black tarry stools. And this is also a result of gastrointestinal bleeding, of course, but the difference is it's not this bright red color, it's blood that's been digested. And it takes on this characteristic tarry color, usually with a very offensive smell, and these individuals will have a difficult time flushing it away. And then the final term, occult, we've talked about this already in the past, but this would be blood that's not detectable by the naked eye and would have to be detected with additional tests, such as the Guaiac test, which we spoke about in Patho 1. So remember, occult bleeding is not obvious bleeding, but the problem with not being able to initially detect the bleeding, these individuals won't notice that they're bleeding, is that it can result in iron deficiency anemia, as we have learned already in the past. So now moving on to this very big, busy diagram, I'm going to point out what is relevant for us for this course, for you to be aware of. So let's start with the first star here. This is showing you some of the major causes of upper and lower gastrointestinal bleeding, and much of these will come up again. So you can see with upper GI bleeding, it could be esophageal varices, a bleeding ulcer, Mallory-Weiss tear. Lower GI bleeding involves intestinal polyps, inflammatory disease, intestinal cancer, and hemorrhoids. And just as a brief explanation of what this condition is here, Mallory-Weiss tear, are these lacerations or tears at the gastroesophageal junction, so where the stomach and the esophagus meet. And so tears there can produce what's referred to as upper GI bleeding. Now, if somebody is bleeding, it's pretty obvious that this is going to result overall in blood volume depletion, which will then have an effect on overall cardiac output. And this, you can see, is the effect regardless of what the cause is of the bleeding. Now, the extent of the effect, of course, will depend on the extent of the bleeding, but in any case, blood volume depletion is a major effect and a huge problem, because it can lead to what is commonly referred to as hypovolemia, so low amount of blood or volume of blood within the blood vessels, and many consequences of that, of course. Now, moving on to this third star, with bleeding, it's probably also expected by yourself that it will accumulate. It can accumulate within the gastrointestinal tract. And this will stimulate an increase in peristalsis. So in other words, motility will increase, leading to diarrhea. And we talked about motility diarrhea today as well. There will also be digestion of blood proteins, and the digestion of blood proteins originating from a major upper gastrointestinal bleed is reflected by an increase in blood urea nitrogen. Okay, so I will say that again, that the digestion of blood proteins from a major upper gastrointestinal bleed can be reflected by an increase in blood urea nitrogen. And this increase in blood urea nitrogen can lead to uremia. And we've introduced that term in the past. This can cause problems with your neurological system. It can lead to problems with the kidneys. There are many different examples. Now, the lower star here on the left is talking about metabolic acidosis. When someone is suffering from hypovolemia, so low volume of blood within the blood vessels, this is it'll make sense that there'll be a decrease in blood flow then to such organs as the kidneys. And this can lead to kidney failure. And when the kidneys fail, their ability to produce bicarb or bicarbonate, as we've talked about in the past, which helps balance out our pH within our blood and keeping it within that very narrow range, which can lead to acidosis. And because it's the kidneys leading to that, it's referred to as metabolic acidosis, which we know is different than respiratory acidosis, as we've already learned about. And this can lead to what we spoke about in our urinary lecture is low urine output, or oliguria. It can also lead to anuria, so A-N-U-R-I-A, which refers to failure of the kidneys to produce any urine. And actually, those terms are right here. Our next topic is intestinal obstruction. There are 4 main types of intestinal obstruction, and they are hernia, intussusception, volvulus, and adhesions. Hernia, to start with, is an outpouching of the small bowel. So the small bowel can protrude into an area that it's not supposed to be, usually through a weak area of the abdominal wall that allows for the passage. So for this example here, if this is the abdominal wall, if it's weak in one area, then under certain conditions of increased intra-abdominal pressure, so someone they're bearing down or coughing a lot or lifting something, then you can get the herniation of the bowel through that weak area or through that opening. This specifically is showing you a type of hernia called an umbilical hernia, which is quite common. So that's where part of the intestinal tract pushes out through the umbilicus. And anybody that ends up working with newborns, this is very common, where they can have an umbilical hernia, and a lot of times it just resolves on its own and doesn't require surgery. Sometimes if it is corrected when they're older, it's more just for cosmetic. But in certain situations, it has to be monitored. Of course, if a parent noticed that the child's belly button region was starting to turn color, then that's of course problematic, because the intestinal tract is now being strangulated. And you have to worry about necrosis and obstruction. Another example of a hernia would be an inguinal hernia, where this is more through the groin region, also quite common, where intestinal pouches or an intestinal loop can herniate out through the inguinal canal. But these can be, because they can lead to an obstruction, because it can lead to ischemia, it could lead to necrosis. In some cases, it is corrected surgically, and it is fairly easy to correct surgically, especially if the bowel itself is in good shape and they don't have to remove any of the bowel itself, but just push it back in. Second example is intussusception. This is sometimes described as telescoping or invagination of one part of the intestine into the other. So you can see that in this picture here. And how we can describe it a little bit more is it's usually the proximal part of the intestine that slides into the distal part of the intestine. If someone experiences exaggerated peristalsis, in particular in young children, it can cause intussusception, and it's easy to correct if it's identified correctly or quickly. And you can see a few reasons why this will be problematic. It could cause an obstruction. It does narrow the lumen of the intestinal tract. You can see that there are openings here which can permit the passage of food, and even the proliferation of bacteria in that area. And you could get reduced blood flow as well to these areas, and then overall reduced peristalsis. The third example is volvulus. A volvulus is a formation of a knot or a twist, and this can lead to bowel obstruction. That's pretty clear by the image. and it can cause ischemia and necrosis. This is a surgical emergency. So this is a very obvious strangulation. And in our final example of an intestinal obstruction, we have adhesions. And these are usually secondary to abdominal surgery. So there's some sort of irritation after surgery that can lead to inflammation and the development of scarring, which can end up forming adhesions. And these adhesions could form an obstruction. And if you think about it, there is a lot of manipulation if somebody's having abdominal surgery of the intestinal tract, and this in itself can lead to what I already mentioned as inflammation and scarring leading to adhesions. And so really there are these bands of fibrous tissue that are forming between abdominal tissues. They can even form between organs. We spoke about the different types of intestinal obstructions on the previous slide, and this slide summarizes the various complications that can occur because of an intestinal obstruction. And so in this image on the left, this is showing you the intestinal tract, and normally food would move in this direction. And we could say then it's moving really from proximal to distal. We could even say relative to the obstruction here that this is proximal to the obstruction and this is distal to the obstruction. Let's start at the top of this flow chart. If there's some sort of intestinal obstruction, whatever it may be, it can lead to the sequestration of gas and fluid and even fecal material proximal to the obstruction. So this is proximal to the obstruction. So when you get accumulation of fluid, accumulation of gas, formation of gas, it's going to end up causing distension because it's not supposed to be remaining in this area and it just continues to pile up. And this distension is going to end up causing pain, and it's usually described as a colicky abdominal pain. When these individuals experience this pain, it can lead to the reduction in their food intake. They don't want to eat. It can also signal nausea and vomiting. And so that's listed here. And naturally, if you're vomiting, then your fluid and electrolytes will be lost. Also, if you are very nauseous, you might not want to consume fluid, and you won't want to consume food. So we can see problems with nutrient absorption, whether it's because we're throwing it up or we're just not consuming food. And eventually, the body will start to pull from its stores because it's not getting the nutrients it needs, so it will pull from carbohydrate reserves and utilize that, but eventually we can deplete the reserves. And so ultimately we have this loss of water and electrolytes, which could, depending on which electrolytes are lost and to what extent, could have an alkalotic or an acidotic effect. Okay, so in addition to the distension causing pain, the distension can become so extensive that it puts pressure on the diaphragm. Okay, so the abdomen gets bigger and bigger and bigger and ends up compressing the diaphragm. And if the diaphragm is compressed, then it can prevent proper expansion of the lungs, because we know that with inspiration, our diaphragm drops down and our thoracic cavity opens up in order to fill our lungs just normally. And so with this reduction in diaphragm contraction, because it can't move down, the abdomen has grown so large that the lungs don't become properly ventilated. It can cause compression on a particular area of the lung that can lead to atelectasis. And so remember that atelectasis is where part of the lung collapses. And so this could predispose an individual, if their lungs are not properly ventilated and the lung collapse, it can predispose somebody to developing an infection causing pneumonia. And now moving to the lower part of the flow chart, if there's prolonged wall tension, so we can see that tension here on the wall, it can lead to a reduction in arterial blood flow to that area, to that tissue, which we know can lead to ischemia. And you can end up with necrosis of the tissue. It can end up stretching out so much that it perforates. It's so weak that it breaks open. And if it breaks open, that's a major problem, because all of the contents then that are supposed to be remaining within the digestive tract that are toxic to the rest of our could be toxic to the rest of our body, now leave because of this perforation. And when this happens, it can lead to what's referred to as peritonitis, so inflammation of the peritoneal cavity. And this can lead to sepsis. But also, the wall tension will damage the vascular system in the area, and this can promote what's referred to as bacterial translocation, where the bacteria can actually leave and translocate from its location inside the bowel outside, and that can also lead to peritonitis, which could end up leading to sepsis. And then the final comment to make is because of this damage in circulation in the area, it can lead to hypovolemia. So again, reduction in the volume of blood within the overall circulatory system, which could ultimately lead to shock. Now we'll talk about esophageal disorders. So disorders of the esophagus. The first disorder we'll talk about is gastroesophageal reflux disease, which you may have heard of as referred to as GERD. And this is the reflux of chyme containing acid and pepsin from the stomach to the esophagus. So what does that mean? Well, when we consume food, normally it's traveling down the esophagus. It will pass through a very important sphincter called the lower esophageal sphincter, or sometimes referred to as LES for short. And if the lower esophageal sphincter is working properly, so that's right around this location here, food will pass through. Very powerful, strong digestive enzymes, acid and pepsin are going to be breaking down the food. But the stomach is designed to deal with that. It has, you might remember, mucus secreting cells that help protect the lining of the stomach from these very powerful digestive enzymes. And then food is referred to as chyme at this point, will leave through the pyloric sphincter and enter into the small intestine, where we know most absorption takes place. Now, if the lower esophageal sphincter is not functioning as well as it should, then we can end up with the reflux of chyme into the esophagus. And the esophagus, the tissue that makes it up, is not designed to deal with the acidity. It's not designed to deal with these powerful digestive enzymes. And so it can end up leading to what's referred to as esophagitis. So inflammation, remember, is itis. Inflammation of the esophagus due to the reflux of chyme. And that can be very irritating for individuals. And sometimes people will describe it when they feel it in this region here, which is a common place. They might describe it as heartburn. And sometimes in an otherwise healthy person, maybe during stressful times, and you may have experienced this yourself, where you feel what you might say indigestion or heartburn in the chest, and that can be because your lower esophageal sphincter is a little bit more relaxed than it should be, and it's permitting the retrograde or backward movement of chyme, and it feels like a burning sensation because it's acidic. But oftentimes it's something that clears up in a short period of time, but there are people that have chronic problems with the lower esophageal sphincter, and over time it can lead to pretty extensive inflammation of the esophagus. Over time, this reflux esophagitis or inflammation of the esophagus can lead to the formation of ulcers. So here is your stomach, and here's your esophagus, and you can see the formation of ulcers. And these ulcers can even bleed. They can form even scarring in the area. People that suffer from GERD will oftentimes describe it as pain that they feel in the chest, the heart region, after a meal. And this is referred to as postprandial heartburn. But it's non-cardiac because it's not a heart attack. The heart isn't damaged. It just is sometimes perceived that way because of the location. Postprandial referring to after a meal. So they get this heartburn after they eat, when digestion starts to take place, and then the regurgitation of chyme occurs. Okay, the next very important point to make is that individuals could end up developing what's referred to as Barrett's esophagus. And this is when the normal esophagus epithelial tissue or esophageal epithelial tissue is replaced with cells that look like gastric epithelium. Well, that might be a somewhat familiar description because we spoke quite a bit last term about metaplasia and we spoke about it from the perspective of bronchial metaplasia, where if somebody is smoking, the bronchial cells over time can change to a cell that can handle the irritant that they're constantly exposed to. But the problem, of course, with that is those cells are not supposed to be there. They're not designed to be there, and eventually these metaplastic cells could become atypical and could end up becoming dysplastic and then possibly developing cancer. So with Barrett's esophagus, the normal squamous epithelial tissue of the esophagus turns to a cell type that resembles the stomach, which is more of a columnar epithelial tissue. So that's a form of metaplasia. And this can become dysplastic, and these individuals can develop cancer. Our body was designed in such a way as to handle the normal everyday events that it should be exposed to. And in the case of the esophagus, the squamous epithelial tissue is a type of tissue that can handle abrasive substances. For example, you're chewing a pretzel and then you swallow it. There's sharp ends to the pretzel, but that squamous epithelial tissue can handle that. But it's not designed to handle acidity and digestive enzymes in the same way that the stomach is, where columnar cells are quite populated in that area. So people can have part of the esophagus removed if they've developed Barrett's esophagus, and they'll generally replace the part of the esophagus that's been removed with part of the small intestine, so more of a similar tissue type. On our next slide, we're going to talk about hiatal hernias. And before we get to that slide, I want to point out a few things. Here we have the esophagus, and here we have the diaphragm. Normally, the esophagus pierces through a nice opening right here in the diaphragm where it passes down in towards the stomach. So what I want you to understand from this is that your lower esophageal sphincter should be found below the diaphragm in normal cases. But there are situations where it can this part of the stomach can actually herniate upwards. And we'll look at those examples on the next slide. So hiatal hernias are really protrusions or herniations of the upper part of the stomach. And really what's happening is the upper part of the stomach is herniating from, let's say this is the abdominal region, into the thorax, where it shouldn't be. You can see that there are two main types. We have sliding hiatal hernias and paraesophageal hiatal hernias, also known as rolling hiatal hernias. Sliding hernias you need to be aware of are the most common type. About 90 to 95% of hiatal hernias are sliding hiatal hernias. And this is where the proximal portion of the stomach moves into the thoracic cavity or the thorax region through this region here, which this opening in the diaphragm is called the esophageal hiatus. Okay, so the opening that allows for the esophagus to normally pass through the diaphragm toward the stomach. And what will happen in these situations is when a person is lying supine, so lying on their back, the lower esophagus and the stomach end up getting pulled into the thorax. Sitting up will cause it to slide back down, and that's why it's called a sliding hernia. So again, when a person is lying on their back supine, the lower esophagus and the stomach are pulled into the thorax, so moving in this direction. But then when this individual stands up, it ends up causing it to slide back down. And so sliding hernia. And this type of hernia will be exacerbated by really anything that increases intra-abdominal pressure. You can see that the lower esophageal sphincter now is above the diaphragm, And this can lead to GERD because the normal resting pressure of this lower esophageal sphincter in the case of a sliding hernia is decreased, meaning that it becomes more relaxed. The tension reduces, and that permits gastric substances moving from the stomach, where they should remain, up into the esophagus. So we get this movement here. So that's a sliding hernia, and here's another hiatal hernia. Here's another example here. This is showing you the diaphragm, and here is part of the stomach that's herniated upwards, and here is the location of the lower esophageal sphincter instead of below the diaphragm. Now in our next example, a paraesophageal hiatal hernia, also called a rolling hiatal hernia, the greater curvature of the stomach, so let's go back to this slide so I can remind you of that. So that would be this part here. The greater curvature of the stomach ends up herniating upward, and it ends up lying alongside the esophagus. So that's where it gets its name, paraesophageal. It ends up lining, this is a much better way to visualize it here. So it almost lies parallel to the esophagus, so it's called paraesophageal hernia, and it rolls up. So that's why it's sometimes called a rolling hernia. Now, reflux here is uncommon. Why? Well, look at where the location is of the lower esophageal sphincter. It's remaining below. And because of that, it can usually hold on to its normal tone. But the major problem here, and why this is even more problematic, is because the herniated part of the stomach can end up becoming congested, and ulcers can form. It can become strangulated. So that is something that needs to be corrected. Otherwise, the tissue can become necrotic. So I want you to really make sure that you're really aware of the location of the gastroesophageal junction, or the lower esophageal sphincter. And so if we go to the next slide, you can see it even a little bit better. So with a sliding hiatal hernia, remember that we get that movement of the stomach upwards, and the lower esophageal sphincter, or the gastroesophageal junction, ends up being above the diaphragm. Due to pressure changes, now it's not going to remain as tense as it should be, permitting that movement of gastric substances, leading to GERD. So in this case, GERD is likely. Now in paraesophageal or rolling hiatal hernia, you can see that the greater curvature of the stomach is herniated up, lying alongside the esophagus, and you can see the lower esophageal sphincter is below the diaphragm and usually maintains its tone, so you're not going to get reflux in the same way as a sliding hiatal hernia. But of course, the strangulation possibility here and possible necrotic tissue. Also, any substances that are stuck in this part of the stomach can end up getting infected. The final point I want to make, which was not mentioned on the previous slide, is called a mixed hiatal hernia. So this one is more rare, and this one is just quite simply a mix of a sliding hiatal hernia and a paraesophageal hiatal hernia, where you have both the gastroesophageal junction or lower esophageal sphincter above the level of the diaphragm, as well as this part of the stomach that has herniated up, so the greater curvature of the stomach. And so you end up with kind of a double whammy here. You've got GERD for sure that will be experienced, and part of the stomach that could be strangulated. Our final topic on the esophagus is esophageal cancer. It is usually or the most common is a squamous cell carcinoma. It's very aggressive because, and oftentimes diagnosed late. And individuals, their first complaint may actually be that they have a little bit of trouble swallowing. And it can be because there's this mass in the wall of the esophagus, and it tends to form in the lower part. So relating back to what we spoke about with GERD and the development of Barrett's esophagus, that can predispose somebody to the development of cancer. It can be identified with endoscopy. So here's endoscopy showing you the lesions. It can also be identified with a barium swallow. So you can see a barium liquid is swallowed and it can be identified on x-ray. Risk factors include men over the age of 65, those who smoke, alcoholism, and then, of course, Barrett's esophagus. When I spoke about a symptom being difficulty swallowing with esophageal cancer, that term is referred to, the term that is applicable is called dysphagia, and that's difficulty swallowing. And the cause of difficulty swallowing can be numerous, but in this case, what's relevant is that there's some sort of mechanical or physical obstruction, which is the cancer. Now we'll talk about intestinal disorders. We're going to look at inflammatory bowel disease. Right away, I want you to make sure that you don't confuse this with irritable bowel syndrome or irritable bowel disease, because they are very different concepts. The two main inflammatory diseases that we will talk about are Crohn's disease as well as ulcerative colitis. Both of them are chronic. Both of them involve relapsing, and there's really unknown origin, but the incidence is increasing around the world. They're very inflammatory, and they can both produce diarrhea and bleeding. So you can see here the similarities outlined in red. Then some of the differences are also highlighted. First, in terms of differences, let's look at the location affected by these conditions. When it comes to Crohn's disease, it affects anywhere in the GI tract, anywhere from the mouth to the anus. It can affect the esophagus, for example. Crohn's disease has what are referred to as these areas that are segments that are affected by the condition. And then other segments are not affected by the condition. So it's like it affects one area, skips a segment, then affects another area. And these are referred to as segmental or skip lesions. In addition with Crohn's disease, and we'll see this on the next slide where it'll put a lot of these differences into a picture for you, is that Crohn's disease can affect one side of the intestinal wall and not necessarily the other. So when you think of or remember how we have the intestinal tract, with Crohn's disease, it can impact this one side here and not affect the other. When it comes to ulcerative colitis, this is going to impact the colorectal region. So that's where it gets its name, colitis, inflammation of the colon. And ulcerative because ulcers are common. But it has continuous lesions. So instead of these skip lesions where it affects one area, so Crohn's might affect here and then it might affect here, when it comes to ulcerative colitis, it's going to be continuous, so all throughout that region. There is a strong family history associated with Crohn's disease, although overall idiopathic in terms of cause. Ulcerative colitis does put somebody at an increased risk of developing colon cancer, because remember, we have these ulcers that form that could predispose someone to cancer formation. And with Crohn's disease, the development of granulomas are common. So a massive granulation tissue that is in response to the chronic inflammation of the walls of the intestinal tract. The images on this slide help put some of what we discussed on the previous slide into a visual perspective, and then I'll add in a couple other pieces of important information in terms of differences between these inflammatory diseases of the bowel. Starting with Crohn's disease, we spoke already about the skip lesions that are present. So it's where you skip one region, it affects the other, affects another, and you can see that in this image here. Here's one area that's affected, here's another and another. And remember that Crohn's disease can affect anywhere along the gastrointestinal tract. Shown here is just the entire large intestine and the rectum and the small intestine, but it can affect other areas as well. Whereas if we look on the ulcerative colitis side, we can see that the area that's affected is in the colorectal region. So we have the descending colon, the S-shaped sigmoid colon, as well as the rectum as being the main area that this disease will affect. Another point to make is that when it comes to Crohn's disease, the inflammation affects all layers of the wall that make up the bowel. And so we get transmural inflammation. So you can see all the different layers here that we know make up the intestinal tract, and you can see the transmural inflammation. Whereas when we look at ulcerative colitis, it's important to know that it only affects the mucosal layer. And what happens with ulcerative colitis is we get these ulcerations. So you can see ulcerated tissue here, ulcerated tissue here, and here, and it forms what are called pseudopolyps. A polyp is normally something that we would picture as something that forms and hangs off of a structure, and we'll look at this on an upcoming slide. But these are pseudopolyps, pseudo because they're not really polyps, but they look like polyps because of the erosion of tissue on either side of it. On this slide, we're going to speak about diverticular disease, but first we'll go through a few definitions that look very similar but are actually very different. Diverticular disease is a disease of the colon. It tends to happen in weaker areas, and you can think of this disease as consisting of these herniations of both the mucosal and submucosal layers through the muscle layer. And so diverticula then are these sac-like outpouchings of the mucosa and submucosa, or the herniations as I mentioned initially. And so these can be present all throughout the colon, and their existence in themselves might not be problematic, but those that have these diverticula are diagnosed with diverticulosis, osis referring to condition, which is a condition that is asymptomatic. So they possess these diverticula, but they don't have any symptoms of it. However, diverticulitis, there's that word itis, is inflammation of the diverticulum. And this can lead to rupturing of the diverticulum, which can lead to peritonitis, where fecal material can enter the abdominal cavity. Now let's have a look here a little bit closer so that you can understand what these diverticula look like. So here are these sac-like outpouchings, and what you can't see from this internal and endoscopic view is it just looks like openings. But really, if you can picture it ballooning outward. Okay, so outpouchings, and we can see in the next image here a little bit closer or a little bit clearer those diverticula, which on the inside look like these openings and on the outside look like these balloon structures. So if a substance gets trapped in there or obstructs that region, then it can promote inflammation and it could even lead to infection. And diverticulitis is a very painful and uncomfortable experience for those that suffer from it. The final comment I'd like to make about this condition is that it used to be thought of as a disease of the elderly, but now it's seen often in people who eat a lot of refined foods. And people that eat a lot of refined foods are said to have a very low residue diet, and a low residue diet reduces fecal bulk. And if fecal bulk is reduced, then the diameter of the colon will also be reduced, which can increase pressure within that area, cause potentially inflammation of these diverticula, which otherwise might not be problematic, and then possible rupture. Now we'll talk about appendicitis. The appendix, you probably remember, is an accessory organ that hangs off the cecum. So here we have the small intestine would be all through here. Here's the final part of the small intestine called the ileum. So remember, with the small intestine, we have the first food will go through the duodenum, then the jejunum, and then the ileum, at which point it will enter the large intestine. This lower part of the large intestine is called the cecum, and then we have the ascending colon, transverse colon, descending colon, sigmoid colon, and rectum, and then anus. And here you can see the vermiform appendix, which is this worm-like structure that hangs off of the cecum. Now, it used to be thought of as a structure that had really no purpose, but it does possess a lot of good bacteria, that good healthy flora, that in the case where, let's say, somebody's intestinal tract has been depleted of their good bacteria, maybe they've been on antibiotics and it seems to clear everything out, vermiform appendix can help repopulate that normal bacteria that keeps us healthy. So really part of our immune system. And if you remember too, it's the large intestine that possesses extensive amounts of good bacteria. So if an obstruction occurs, let's say food ends up getting stuck in here, it's a major problem. And it doesn't take much to obstruct it. Inflammation can occur, infection can occur, and it can burst. And if it bursts, you have infective substances that pass all throughout the abdomen, and it can be very toxic and quite a messy cleanup for a surgeon. So it's a lot easier to just remove an inflamed appendix than clean up the mess that it leaves if it does burst. So of course that can lead to peritonitis. That's come up a few times. So bacteria and fecal material entering the peritoneum, and it can cause death if it's not cleaned up quickly. And so even anything that is stagnant, we've talked about this with the urinary system, like if there's an obstruction here blocking this region, you can have stagnant bacteria in here that continue to multiply or proliferate, and it ends up causing appendicitis. And the final comment to make on this is a test called McBurney's, or a location referred to as McBurney's point. There are different orthopedic tests that can be done on individuals when appendicitis is suspected, but this is just one example. This is the name given to the point over the lower right side of the abdomen, and there is a specific method of locating it, and it roughly corresponds with the most common location of the vermiform appendix. So this region here. And palpation in this region can elicit a lot of pain in these individuals if it's inflamed. Okay, colorectal cancer, 2 slides left. Colorectal cancer is cancer of the colon or rectum. And it looks like, colon cancer looks like neoplastic polyps, these new growths that hang. These polyps you can see represented in this image here. So here is a polyp that is not normal, should not be there. And they have a stem. They can be benign, they can be malignant, but of course in this case we're speaking of cancer, so we're talking about malignant. You can see in the right image that these cancers can form in different regions of the large intestine or in the colon. But most cancer of the large intestine is found in the descending colon through to the rectum. So we're going to circle this whole region, the descending colon through to and including the rectum. So we have 5% for the descending, 25% for the sigmoid, and 20% for the rectum. So 50% then of colorectal cancers are occurring in this region. And this is easy to access through rectal exam, or more in particular colonoscopy. And so if polyps are identified, they can be removed so that they don't end up forming cancer. Symptoms are going to vary depending on the location. So if you read a little bit closer here, you can see that there's generally more pain that's felt in the ascending and the transverse colon when cancer is there. But when it comes to the descending colon, or sorry, I should say the sigmoid and rectum, where you can see most occur, these individuals could have blood in their stool, but they'll have change in their bowel habits versus pain that you see with ascending, transverse, and descending colon. So it's important to take a thorough history like anything. Very common cancer in Canada. So very important to understand it. And of course, if cancer forms, it can form an obstruction, which can lead to additional issues. Most colorectal cancers are adenocarcinomas. Remember that adenocarcinomas are malignant tumors that are formed from glandular structures, from glands. And finally, the most common location for colorectal cancer to metastasize is to the liver and to the lung if it's not caught in time. And on our final slide, the development of colorectal cancer from polyps. It takes years or even decades to develop colorectal cancer, so it just shows the importance of screening through colonoscopy once you're at a certain age. They start off as these polyps that can become covered with cells that are atypical. So we can see these atypical cells here, or focal atypia, also known as cancer in situ. And eventually it can invade, and you can see that over time you're getting worsening of the amount of atypical cells. And what you can also see is that over time the polyp is really overtaken by the cancer. You can see it disappearing. So at the end here we have this ulcerated invasive cancer without any polyp remnant. And so if polyps are found, as I already mentioned, if they're found when somebody's asymptomatic, then they can be removed and cancer can develop. And I know how serious this can be and the effects that it can have, because one of my very close friends, since we were really young, at the age of 29, had colon cancer, and very, very unsuspected in somebody of her overall health, but for whatever reason, she was very unfortunate and she passed away at a very young age because of it. So because we know, though, that this can happen with age, as we age, and we also know that it takes a long time for it to develop. I said years and even decades. Hopefully that tells you that you need to take care of your digestive tract now while you're young, eating healthy and making good choices, really preserving your gut so that you don't end up developing polyps and any other conditions. Okay, that's the end of today's lecture. Thank you for listening.